The Director General of the Nigerian Institute of Medical Research (NIMR), Professor John Oladapo Obafunwa, hosted several media practitioners at the Institute's boardroom on Tuesday, February 25th, 2025, to review their research findings on emerging and re-emerging infectious diseases across Nigeria. Several executive board members of NIMR were present at the event, including the Deputy Director, Professor Rosemary Ajuma Aldo, Dr. Bitrus, the Director of Admin, Dr. Kunle Okpechioma, the Research Director Board Member, as well as Professor Ezechu, Director of Research Board, among others. Professor Rosemary Aldo, the Director of Research and Deputy Director of NIMR, as well as a Professor of Medical Research at Leeds City University, led the research findings summary session following a brief opening remark from the Director General, Professor Oladapo John Obafunwa.
Today, we'll be focusing on one of our directors, one of our researchers, in the person of Professor Rosemary Aldo. Our area of interest is likely in the hemorrhagic fevers. Talk about Lassa, dengue, Ebola. Of course, when we talk about viral infections, that will take us into the realms of other things like hepatitis B, hepatitis C, Mpox, and of course recently we've been hearing about the so-called reemergence of human metapneumovirus. We're all familiar with COVID. Nigeria has had its own share of Ebola, and thank God that we're able to contain that. So we'll be hearing more about these things. And it is my hope that these and future engagements will expose the contributions of the Nigerians of medical research to health development in the country. Again, on behalf of Nigerians of Medical Research, I welcome all of us to this second edition of the Media Chat. It's nice seeing so many faces representing different media organizations. Incidentally, there are a number of faces that I can recognize. I won't get into that. But I want to say a big thank you to our colleagues in the media. After the first edition, it's very refreshing that you did your best to tell the public about what NIMR is all about. It's my hope that as we continue on this journey, we'll get more of people at large, the man on the street, technocrats, policy makers, legislators, to further understand the role of Nigerians of medical research, what we are doing, and what is it that we've been able to achieve. And co-researchers in the various laboratories, they will share with us what they are doing, what they've done, and how this has impacted on the lives of Nigerians, apart from global contributions.
Professor Rosemary revealed that the research was crucial to understanding how viral diseases spread, their effects on the general well-being of the public, and how to prevent the outbreak of deadly infectious diseases. She made references to past researches, findings, and achievements backed with statistics and figures.
We know that these emerging and re-emerging diseases are becoming a big issue. You know, every day you listen to the news, there's an outbreak here or there. It's something that, and it results in a lot of morbidity and mortality. And so it's important that we do research, you know, for us to be enlightened, to understand these infectious agents the more, so that we can come up with diagnostic kits, vaccines, treatments, you know. And of course, we know that currently it's a global village. The world is a global village, and infection in one point can spread very rapidly to another. So we do not work in silos. We work even with other researchers in different parts of the world, so that together we can combat these diseases.
Furthermore, Professor Rosemary discussed the recent COVID-19 pandemic, recounting NIMR's intervention in sequencing the first case of SARS-CoV-2 in Nigeria.
From the COVID-19 pandemic, you know, we're being provided information every day so that false news will not spread and cause more harm, as it did in Liberia and Guinea in the time of Ebola. So some of the key achievements of my research here in NIMR, we started in Ondo State. My team, we went to Ondo State. There was an outbreak of Lassa fever in Ondo State. And as at that time, it was the biggest, you know, more mortality and morbidity. So we were there, we collected the samples, we interviewed people, and by the time we did the screening, just like we see even now, we found some positive cases from amongst those suspected cases in the hospitals, from amongst health workers, from amongst their contacts, their relations, and from the people in the population. We were able to pick some positive cases. But one thing that struck us was that out of about all of the samples that we collected, about 80% of them, from suspected cases, 80% of them, we were not able to identify Lassa fever. We couldn't confirm Lassa fever in these people. So it means there are, and it gave us some concern, it means there are some other things causing infections that mix Lassa fever, the symptoms of Lassa fever, that we are not looking out for. And that was how we expanded the scope of our work to look at viral hemorrhagic fevers as a whole, you know, the panel of viral hemorrhagic fevers that are common in Africa.
Professor Rosemary discussed Mpox outbreak, stating that the Institute's combative efforts led to the discovery of Mpox in stored samples, high-risk individuals, and suspected cases. Following the references to the research backgrounds, Professor Rosemary then revealed the impacts and implications of the recent studies conducted by the institution. She provided insight on the challenges and solutions to emerging and re-emerging viruses, stating that in place of limited funding, exploration of grant opportunities would aid further interventions.
In Kwara State, in 2018 to 2020, we adopted a method of doing this study. I must say that the work we used for the funds we used for the research was provided by Nigerian government. It was not funds from outside. Sincerely speaking, if we don't handle our problems ourselves, we will continue to remain there. For as long as it's not, you know, spreading to the third world or to the developed world, we will just remain there. So fortunately, since 2017, we have had support from the Institute with funds from the Nigerian government. And we adopted an approach using postgraduate students who are working in MSc students, PhD students who are interested in viral hemorrhagic fever. And so we had them in different states where they are working, collecting samples, bringing them here to us here in NIMR, and we're screening, and they get their results, they defend their PhD and whatever and move on. But we know the data is important for Nigeria. So one of the PhD students worked in Kwara State, and we found Crimean Congo hemorrhagic fever virus between 2018 and 2020 in febrile patients and in herdsmen. Herdsmen, they were not febrile cases, just herdsmen that take care of cattle. In fact, the prevalence was really very high amongst them. Then also, there was this outbreak of yellow fever in Delta State, because we have an outstation in Delta State. They called on us in NIMR. We went there and we were able to pick yellow fever virus from some of the suspected cases. The federal government, state government, everybody rallied around. They vaccinated the people there. They fumigated the area because it's mosquitoes that are the vectors for yellow fever. So we had to wait until about 8 months after the fumigation. We went to the community, the local government that was a hotspot. We collected mosquitoes from there. We came here, screened them, and we still found out of the 22 pools of mosquitoes, 20 out of the 22, 21 of them were still positive for yellow fever, waiting for another outbreak again. It's just for the mosquito to bite humans. And of course, we provided that information to the state government. It means the fumigation, they probably will have to review again and see, is it probably the pesticide or the insecticide that they use is not effective. It could be that they have developed resistance. Whatever it is, we provided that information for them to handle. Then also within that period in Delta State, we have an outstation, so we have been in Delta for a while. Between 2021 and 2022, we also picked Zika positive cases from febrile patients, right? And then we also picked chikungunya virus. All of these viruses are viral hemorrhagic fevers. These are viruses that can cause not just morbidity and mortality, it could also affect the organs and result in bleeding, which results to death. So these viruses were able to pick chikungunya virus, and then dengue. Dengue virus we also picked in Oyo State between 2022 and 2024, and in Delta State. We also picked it even in mosquitoes in these states. So it's like, in fact, I recall when we started a project we're doing with our collaborators in Senegal, they said that dengue is an issue in their country. I said, no, that's not our own problem here. I think malaria is our problem. But when we went to the field, the prevalence of dengue fever is really very high because we haven't been screening for it. We didn't know. We're just groping in the dark. So many people who have febrile illness, they screen them. It's either they say they have malaria or typhoid, and that is it. Okay, so they just over-treat people. But besides these ones, we have many other viral agents that are causing infection. But because we have challenges with diagnostics, they are not able to unravel or discover them. Then also, from the mosquitoes that we were sampling mosquitoes that carry viruses specifically, and that is the Aedes aegypti mosquitoes, not the Anopheles for malaria. I'm not a parasitologist, so I just focused on the ones that carry the viruses. Aedes aegypti. We found an abundance of Aedes aegypti in Delta State, in Oyo State. We have plenty of it there. So, along the line, as we're working on the viral hemorrhagic fever, the COVID-19 pandemic came knocking. And in this institute, we sequenced the first index case, do partial sequence we did. We're the first to report that. What that means is that, when you know the characteristic of the virus you're working with, and you are able to load it in the gene bank, when they are going to develop vaccines or develop drugs or diagnostics, they will also take from your own, okay, and include. And that's why, because we have not been doing much of this sequencing in country, because we have not been looking for these agents mostly. Sometimes the kits we get from abroad, we use them and they are not able to pick cases here in Nigeria. So we were able to develop it. And so when we talk about sequencing, that is just the beauty of it. That is the added advantage, that what we have can be reflected in any diagnostics or vaccine or therapeutic. Then we also reported the seroprevalence of SARS-CoV-2 in Enugu, Gombe, Lagos, Nasarawa, as well as Delta and Sokoto states. At that time, because of the strategy we used, we're just treating those who had, testing those with a narrow criteria for testing. If we were to test everybody, we would not have enough test kits. So the wisdom of the leaders was just test those who are coming from outside with symptoms and stuff like that. But it was like, are we sure that this is the true prevalence of this virus, this disease in Nigeria? By the time we did the seroprevalence in these states, we saw that we had higher prevalence of seroprevalence of COVID-19, SARS-CoV-2 in Nigeria. We had ranged between 18 and 30%. So it means that the disease was spreading, but asymptomatically. People were not showing symptoms. But because we did this survey in the healthy population, not people who were in the hospital, and we saw that a good number of them, at least 1/3 of the population that we screened, had antibodies. So it just meant that, okay, it is spreading, that's one. Number two is the fact that we have not reached herd immunity. Infection will continue, so we will benefit from the vaccines. Okay, so it was just important that we take the vaccines before people get infected and those who are at risk may die.
In conclusion, Professor Rosemary warned about the prevalence of emerging and re-emerging infectious diseases in Nigeria, particularly the viral hemorrhagic fever, while advising that proper screening be done for early detection and prevention.
For public engagement, we have communicated our findings, our research findings to stakeholders. Some of the states, we gave them information at the national level also. We have also presented some of our findings in both national and international conferences. We have published a few in scientific journals. And I know that it's very important that the public understands how these agents spread and know they need to have some more information, both the public, the health workers, and it's in so doing that we'll be able to control this emerging and re-emerging infectious disease. So I see this media chat as really very, very important because I'm sure it's going to enlighten the public the more. So, in conclusion, I'll say that emerging and re-emerging infectious diseases, particularly viral hemorrhagic fevers, are common in Nigeria. From the results I have presented so far, you will agree with me that it's really with us here. So highlighting the need for screening of febrile patients, okay, not just for malaria, but some of these viral hemorrhagic fevers. And so to better address this, we need improved diagnostics, vaccines, and even treatment. And then additionally, we need to enhance surveillance systems in Nigeria.
Several questions were raised about what Nigerians should be on the lookout for and how the speculated rise in emerging and re-emerging infectious diseases could be tackled. Widespread fear of vaccine resistance and safety, antimicrobial resistance issue, and effective diagnostics, as well as the rising cases of tuberculosis across Nigeria. Dr. Kunle Okpe Chioma, a senior researcher in NIMR's research department, tackled questions arising from the accessibility of tuberculosis treatments in Nigeria.
We have capacity here in NIMR to detect drug-resistant TB. We have the molecular method, and we also have the conventional method, which is culture and phenotypic drug susceptibility testing. So those are the methods to use to detect TB. And I said earlier, now we are moving to genomics. With genomic, you can also use it to detect drug-resistant TB, and it's faster than the ones we have been using, the conventional one, which takes like 8 weeks for culture. Then if you want to do the drug sensitivity testing, it takes 3 to 6 weeks. So the molecular method now is shortening the time for diagnosis. so that the patient can be put to treatment promptly with the correct drugs. Then we have other drugs. There are newer drugs now available that they use to treat multi-drug resistant TB. So those newer drugs now, we also have them test them in the lab, and we discover that most of the MDR patients, they are responding to the treatment. But these drugs are not readily available because they are newer drugs. For you to get them, you have to go through the National TB Control Program. So the National TB Control Program have drug treatment centers where those patients can go to, and the treatment will be administered to them. So if you go to the patent stores, you will see all those drugs. That's why the National TB Program control the TB diagnosis and management. So the patient have to go to the hospital that are working with the National TB Program and get treated. So those drugs are effective. Then free? It's free. It's free for all TB treatment is free. So far you go through the National TB Program, hospitals or lab. So TB is free.
Further questions bordering on adequate funding and budgeting were tackled by Professor John Oladapo Obafunwa, as she provided an inside information on the funding structure of the institution, including emerging challenges in the health sector such as accurate diagnosis of various strains of fever and feverish conditions.
Let me start with 2025 budget. We don't know what we are getting. All I know is that we've gone to defend the budget as at about 19th of January. Questions were asked. Why do you need this? Why do you want that? So, as at this point in time, I don't know what we are going to get. Maybe by next month, about this time, one might have an idea what we are going to get, or what we've been given. I realized that some of the samples they were sending to us, or many of the samples being sent to us for analysis, were not accompanied by detailed clinical information. And as a pathologist, if you send certain samples to me in the laboratory, I have what we call rejection and acceptance criteria. If you don't provide the relevant information to me, I'll throw it back at you. Because it's garbage in, garbage out. If you want me to do an analysis, you should be able to tell them, you should be able to provide me basic information: age, sex, address, social status, including occupation, basic clinical history, the clinical complaints, and drug history, social habits. We are not breaching confidentiality in this case. We are providing the basic clinical information that will assist me. And if I don't have that information, I won't be able to help you or the patient. And when I was given that information, I told the person, I said, maybe we should start thinking of rejecting samples. Maybe we shouldn't reject samples. And I said, no, we are talking about quality assurance.
Indeed, this nature of conversation is geared towards raising awareness among the general public on health consciousness through timely and effective health education and forums such as these. For Echo Hot Blog, this is Daniel Samson Idowu.